Yeah, great. So it is a very big nodule. You can see tons of pigment, weird scanning artifact here. But as it comes into view, you can see it. With all the pigment, you could think about, at first glance, a deep penetrating nevus, maybe cellular blue nevus, pigmented epithelioid melanocytoma, aka animal type melanoma, aka epithelioid blue nevus. Those are things that can be very heavily pigmented. And I think going closer, that would be a consideration that you might think about down in here because you've got big epithelioid cells, plump, pretty atypical as they come into focus. This scan's a little out of focus, I think because of all the pigment. I think it made it harder for the scanner to pick up. But you can see they're big, they're atypical. Epithelioid have big nucleoli in nests and kind of long, plump fascicles. Tons of melanophages in between, right? Also some melanin in the cytoplasm. So you could think about that. That would be one consideration. And so pigment epithelial melanocytomas, again, called by several different names, that'd be one consideration. And I find those kind of challenging to diagnose, but one important thing is that they usually have loss of what marker is a gene, and we have a protein that we can test for. It's Parkar 1A1, and that's, remember, those are the ones that are associated with Carney's syndrome, and the gene for that is Parkar 1A1, which you can remember, park your car in the garage for Carney's. So anyway, so you can do an immunostain for that. So but that's not what this is, but I think that'd be an important differential looking at this. The key here is look at the top. When you go up here to the surface of this lesion, it's obviously melanoma, right? There's tons of nests consuming the epidermis, eating their way through the epidermis, pagetoid spread up in here. Again, very atypical. There's mitotic figures. I've passed over a couple. Again, it's a little out of focus, but so that's always an important thing is when you see a melanocytic lesion, make sure you check out what's going on in the junction because a lot of times that can kind of give you clues to what the lesion actually is. So this is just an example of a very heavily pigmented melanoma. Some people could say that this is like a blue nevus-like melanoma, although I don't really think so because the cytology is not like a blue nevus. But I think you could find people using terms like that because it's so heavily pigmented. And sometimes the heavily pigmented lesions can be a little challenging, especially when the pigment obscures the cytologic detail. Here we can actually see the cytology and it is not good. All right, so melanoma with a bunch of pigment. Whoa, artifact. All right, what's going on here? We got this here. And then this over here. What would you say about this? Any takers? Yeah, good. There's a scar here, right? Vertical vessels, parallel fibroblasts with collagen, abnormal. It's not like total effacement of the reedy, but the reedy pattern's messed up, and there's regenerative changes in the epidermis. And then next to it, we got something. So let's say this was maybe an atypical nevus or even a melanoma excision. Probably not a melanoma excision because it's so small. I don't know for sure. I don't know the story on this, but so this is next to it. So then what's going on here? Good. Very good. Yeah, it's golden, orangey brown, refractile. We can't really see refractile well on scanned images. I love digital slides for a lot of reasons, but one thing that I feel is lacking is you can't do the flipping of the condenser, which I find helpful to see the refractile kind of three-dimensional nature of things. So yeah, this is something that we rarely see in practice because the dermatologists we work with don't use Monsels, and I think for good reason. So Monsels is, what is Monsel's solution? Anyone want to tell me, or you want to tell me, Amy? Good, because I always forget it's if it's ferric, subsulfate, subsulfite. So I always get it confused. So I trust in the derm residents to know. Yeah, it's an iron-based solution, right? And it's used for chemical hemostasis. Nowadays, most of the people I see in dermatology use aluminum chloride drysol, which, I don't know why people would still use Monsels because Monsels leaves this pigment and this iron-based pigment, and that pigment can be seen on the skin surface. It can leave like a dark spot on your skin. So that's unsightly. Also, the problem is that microscopically, Monsels leaves a lot of pigment and also generates a really brisk fibrohistiocytic host reaction. So that can be problematic if you've never seen this before, because especially on a melanoma excision, you'll see that it's right next to the scar, and there's pigment, and there's spindle cells, and there's going to be some mitoses because this is reactive myofibroblasts and histiocytes. And I have actually seen times where, trainees who had never seen this before thought that this was maybe some spindle cell melanoma or something. Now, this case is not very atypical, but I have seen Monsel's reaction before that was really brisk and robust spindly response, and it looks quite different and quite a bit more cellular than you would see, say, for aluminum chloride. So yeah, it's iron-based pigment that looks a lot like hemosiderin. I think it will stain on an iron stain. I'm pretty sure that it would. I don't think I've ever done it actually, but I would assume that it would stain on an iron stain. I don't know why it wouldn't. To me, it looks quite like hemosiderin, and so you're right. The color's a little different from actual melanin. So, but if you were having trouble, you could do an iron stain, and then there's a histiocytes, fibroblasts. Look, we got a little elastophagocytosis there, which is just, I think, incidental. We see that around healing biopsy sites sometimes in sun damaged people. So that's Monsel's reaction, and the other side has even more. So recognizing the scar is actually a really important clue, and so you can see the Monsels on both sides here of the scar, and then over here in the middle. I'm not sure why it's not in the middle of the scar and it's only here. I don't know why that happens, but it's kind of nodular aggregates. So again, I rarely see this anymore, and I'm not sure if someone's watching this on YouTube and you've got a good reason why Monsels is better than aluminum chloride. I'd love to hear it, because I've never heard any rational reason, except that the people I've seen use Monsels are tend to be a little bit older. So I wondered if it was just that in the past maybe aluminum chloride wasn't as available or people didn't know about it. I don't know. So I assumed that maybe it was just variations of training or generational differences. So hopefully that doesn't offend anyone, and there you go, Monsel's reaction. I have not seen this for several years, actually, that I can recall. We got this side and this side. They look a little different. Any takers? Very good. Cellular Neurothekeoma. I think the main differential you might think about here would be either like sarcoidal granulomas, because the cells look kind of histiocytoid and they're arranged in nests or nodules that look to me a fair bit like granulomas. So that would be one kind of differential here. And then I was thinking yesterday, I don't exactly know how to explain like why that's not a granuloma. It just looks different, but maybe it's the overall pattern, the fact that it's making uh, a discrete kind of mass, and clinically would be like a single, usually skin-colored papular nodule. Maybe that also is partly why. Here, the nests are quite large, so you can have small nests or big nests. And the other differential would be a melanocytic lesion, either like a Spitz, nevus, or even maybe melanoma, because cellular neurothekeomas, despite the name, they are not actually neural. But so the name is a misnomer. No one knows exactly what these cells are, but the current thought is that they're either histiocytic or myofibroblastic or so-called fibrohistiocytic, which is not probably really a thing. We use that term a lot. It's kind of a descriptive term, but anyway, the point is that these cells are not neural. So, and this is confused a lot, and I've got a whole video about this, about the difference between cellular neurothekeoma and so-called conventional or myxoid neurothekeoma, which is actually a nerve sheath tumor and is now known as nerve sheath myxoma, dermal nerve sheath myxoma. And the reason for all the confusion is that this tumor, pretty often, this case doesn't have it, but oftentimes they have myxoid change, and areas that look kind of hypocellular, myxoid, swirly, and nodular that very closely resemble nerve sheath myxoma, which used to be known as conventional or myxoid type neurothekeoma. So thus the confusion. And then with immunohistochemistry, it was very easy to realize, oh, these things are not related, because nerve sheath myxomas, the ones that used to be called myxoid neurothekeoma, they are S100 and SOX10 positive because they are true neural Schwann cell based lesions. They're nerve sheath tumors. these tumors are negative for regular S100 and SOX10. Have been a variety of markers have been proposed for these. They for some reason stain with this variation of S100 called S100A6, which stains a lot of different stuff. They also stain with NKIC3 and PGP9.5. I personally do not utilize these markers. I think that morphology plus negativity for regular melanocytic markers like SOX, S100, MART1 is to me enough for me to be comfortable making this diagnosis most of the time. But other people like those markers, but I find those markers kind of non-specific because they can stain other histiocytic things, other melanocytic things. So you can watch my other video, which I talk about all that in detail. But these tumors often have myxoid change. They often have multinucleated cells. They can have pretty striking atypia, mitotic activity, even occasionally atypical mitotic figures. So this one doesn't have all that stuff, but it's important to know about them because when they have those atypical features, if you mistake this for a melanocytic lesion, you're going to call it like a spitzoid melanoma or something. So, and it's going to be a big, deep lesion. And a lot of times these are on like the face or the shoulder, upper arm of young adults or kids. So, you know, you're going to result in significant surgery and lymph nodes and all sorts of stuff. Whereas cellular neurothekeomas, even when they have atypical features, as far as we know, they have benign behavior. One thing I find helpful is the nuclei pretty distinctly have this very fine, delicate, like pale chromatin that's like kind of open. See that? We call that euchromatin, that kind of cleared out nuclear chromatin. And even on this kind of faded scan, I think you can still see it. It's this fine, delicate, like slightly speckled chromatin pattern, kind of resembling histiocyte nuclei, but I do feel like it's kind of a reproducible finding in cellular neurothekeoma. So that's a bit of a subtlety, but you can try that out and see if you like it. So cellular neurothekeoma, kind of a fascinating entity with a confusing name. Okay, 5. Very good. Yeah, so these are a lot easier when you have an excision and you can see the scar and then you can see normal tissue next to it. When you have a small shave and no clinical photo or history, it can be much harder because scar is hard to recognize at first, I think, when you don't have practice. Because like, see, like here, your eye just sees pink in the dermis and there's not much cellularity. So it's sometimes without practice, it's easy to say there's nothing in the dermis. The dermis looks normal. But when I go back here, the dermis is not normal, right? The collagen pattern is different here. There's like this, the bundles are smaller and packed closer together as opposed to the big, chunky, thick reticular dermal collagen bundles. And also there's more vessels and the vessels are pointed vertically. So you know that those are all clues to scar. But I think though that's one problem is that when you have a small sample of a scar without any normal dermis, or a small sample of any time where there's abnormal dermal collagen, morphia, things like that, it's harder to interpret that when you don't have normal to compare it to. So anyway, there's pigment up at the top, kind of almost looks like a lentigo, but when we look closer, there are actually nests and a lot of single cell melanocytes trickling along the bottom here, these bigger guys that are kind of atypical and don't have as much pigment. They're trickling along the bottom. There's a lot of pigment in the background. There's pigment in the melanophages in the dermis. So you see this and it looks like almost confluent. The cells are a little atypical. You might have a little bit of pagetoid spread. All those things are things that would worry us for melanoma. I mean, this case is not the most dramatic example mimicking melanoma, but some cases can be quite atypical and very closely resemble melanoma, but this is just a benign nevus that has recurred. And so it's important to recognize the scar. It's important to recognize the clinical history. Ideally, I want to either have a known history of a biopsy with a benign nevus at the site, and also even better is if you can find some of the remaining nevus to the sides of the scar or under the scar, which you don't always get that. But here we have a little bit. Look right down there. It's a bit of congenital pattern nevus trickling through the dermal collagen right at the interface of the scar and the normal dermis down here. So that's a pretty nice clue. You don't always get that though. So if they had a benign nevus and now they've got pigment in the scar and you guys take it out for me and I see atypical stuff, but it's confined only over the scar and we know it was benign before, to me, that's totally fine for a benign recurrent nevus. We do not want the atypical things to be going out over the normal dermis to the side of the scar. That would worry us that maybe could be a melanoma. We need to investigate further, check the previous biopsy, make sure the diagnosis is correct, stuff like that. Okay, so see like the atypical melanocytes here, they stop. There they are, and they stop like right here. And then you have a little bit of kind of lentiginous hyperpigmentation. This might actually be the patient's normal skin type. See, their basal pigment actually looks darker throughout their epidermis. So I bet they're a somewhat darker skinned patient. But in any case, the atypical melanocytic stuff stops right at the edge of the scar and doesn't go beyond it. So for you guys in derm and anyone watching this, make sure that you get a good history. If you have a pigmented lesion in a scar, find out what the previous biopsy was, get a copy of the path report ideally if it was done at an outside institution. And then also, if you're going to get a biopsy, it's great if you can get a biopsy showing the normal skin adjacent to the scar and then the pigment so that we can see that it's not going out beyond the scar. So in the old days, people will refer to this as pseudo-melanoma because it can mimic melanoma. Of course, I would not put that on a pathology report because that sounds scary, but it's important, I think, for us to remember in pathology, these can mimic melanoma, right? Recurrent nevus phenomenon. And you can see the same thing in a smaller, more subtle way in traumatized nevi. If you have a congenital pattern nevus or something that someone's picked and then it regrows over the top, it can have a little zone that looks like this. And so that can be a thing that can trick you too. So recognize this phenomenon. Yes. Yeah. Yeah, very good. This is cellular blue nevus. So the first thing is just like you pointed out, from low power, these have a bulbous or dumbbell shaped protrusion pushing down deep. They kind of violate the rule that we usually say that melanocytic lesions should mature with depth. That is, the cells get smaller and get arranged into smaller units and single cells that trickle between the collagen. This does the exact opposite of that. It's most cellular and heavy down deep, pushing down into the deep dermis, or in this case, the subcutis. Up at the top, it's less cellular, right? So that's very typical of cellular blue nevus. You may have one or multiple lobules pushing down deep. And even though we do call it a variant of blue nevus, there is something that seems to be different about these. Both the cellularity and their cytology is different from a regular blue. They tend to occur in different places, like the buttock is a good site, or on the trunk. And also, although this might be somewhat inappropriate, some of my former derm residents have likened the bulbous appearance here to resembling a pair of buttocks. So if you find that helpful to remember, cool. If it's inappropriate, feel free to skip it. But in any case, I think that is a clue diagnostically. We have kind of plump spindle cells or fusiform cells. They may look round depending on the cut, which plane of section we're cutting in. They're cellular, but they're not very cytologically atypical. They're not pleomorphic. They have kind of a vesicular nuclei, like you said, with a kind of open speckled chromatin a little bit, very small punctate nucleoli rather than large nucleoli. If you start seeing really big nucleoli, you could think about melanoma, a blue nevus-like melanoma, or a clear cell sarcoma, which used to be called melanoma of soft parts in the olden days because it can stain like melanoma, but it has a translocation involving the Ewing's gene. That's a topic for another lecture, but in any case, that's the features that you'll see here. But if you see a lot of atypia or big nucleoli, then you would get worried about a melanoma or maybe a clear cell sarcoma. You can see some mitoses. You start seeing a lot of mitoses or atypical mitotic figures. That would also be a time to be worried. Some expert consultation. There is such a thing as an atypical cellular blue nevus, which kind of has an overlap with melanoma and is very challenging, and that's beyond the scope of this lecture, and as I still find very complicated in practice. The cellularity down deep is one thing. There is oftentimes a lot of melanin in melanophages and a variable amount in the cytoplasm. And the other thing is, if you go, I find this a useful clue, if you go up to the top of these lesions and out to the periphery, you'll see areas with much less cellularity trickling between the collagen trapping, like here, sometimes with variable amount of pigment, resemble regular blue nevus. Oftentimes the pigment I find in these is not as
What's it
abundant
on?
as in like a conventional blue nevus, but so we can't really see it on the scan, but if
What's
you
it
look
on?
around in these, you will find little bits of pigment, melanin pigment here and there. But the cells and the
What's it on?
cellularity and the growth pattern at the periphery looks more like a regular blue nevus. This case
What's
is
it
not
on?
cooperating quite as much as usual, but I find that usually helpful. The cellular blue, if you go up to the top
What's it
and out
on?
to the periphery, you'll usually find areas resembling a regular blue nevus. So yeah, just recognize these, and these again, as long as they don't have any really atypical features, they are benign. I feel like
What's it
people
on?
often do try to completely excise them, mainly because if you do a shave, you broadly transect it and you won't see most of the lesion. So yeah, very good. So this is one where at low power, you can see the difference in the texture of the dermal collagen. There is scar-like dense collagen that's packed closely together with increased vascularity, forming a big band here along the whole of the superficial dermis, and then the normal collagen underneath it. And so the one differential would be, is this a scar, like from a previous biopsy? But it's pretty big, right? That would have to be a very broad shave to have left a scar that big. But sometimes it can be impossible to tell regression in a melanoma, apart from, or other melanocytic lesions like nevi can sometimes regress too. But sometimes it's very difficult or impossible to tell scar and regression apart. So kind of history is often helpful there. And also we can have some other clues. In this case, even though there's a lot of dermal regression change, we also still have residual melanoma. We can see atypical melanocytes in the epidermis with confluent growth along the basal layer. There is extension, confluent extension down adnexa, so going all the way down this hair follicle and into the sebaceous gland. These are atypical melanocytes right here, all along there. Also, atypical melanocytes going down this eccrine duct. So sometimes that's really helpful. Sometimes if the epidermis doesn't have much melanocytic activity, looking in adnexal structures can be a helpful clue to whether or not you have confluence. And this patient probably was a little bit older and had some sun damage, so their solar elastosis has been pushed down by the collagen up here. And I like that you brought that up, Li-Ping, because that is a really important clue in sun damage patients. It doesn't work in people without sun damage, but in sun damage patients, if you see a bunch of scar-like tissue or a melanocytic proliferation that's atypical pushing elastic fibers down, that means it's new after the person got old and sun damaged. And new atypical melanocytic lesions that are thick and pushing down elastic fiber, that's a very worrisome thing in an old sun damaged person, right? Just like a melanocytic proliferation that's atypical with scar-like stuff pushing down collagen, that means something grew and pushed down the collagen and then regressed away. Those things are very concerning for melanoma. So the Ben Wood from Australia, a really great dermpath and a brilliant teacher, he has and his colleague Nathan Harvey, they coined this term the umbrella sign, or in this case, the lack of the umbrella sign. When you have a nevus in the dermis, like a congenital nevus that's been present since the person was a kid, and then they get old and sun damaged, the dermis underneath the thick nevus, it only works kind of for thicker nevi, but the dermis underneath doesn't have solar elastosis or has very little, as opposed to the adjacent skin, which usually has a lot. And that's because the nevus has acted like a little umbrella to keep the sun off, and they haven't got elastosis. But if you get a new lesion, it pushes down the elastic fibers, and in this case, we have that problem with regression too, that the new lesion has pushed down the elastic. So we can tell all this is new. In this case, there is no umbrella sign. The dermis has not been shielded, and it has elastosis underneath the process. So that's a really nice, fun, and very useful diagnostic clue that I use in practice. So I learned that from Ben Wood. So out here at the edge, it looks a lot like a dysplastic nevus, and that's just a good reminder that melanomas can have bridging and fibroplasia and have features that resemble dysplastic nevus sometimes. But here we've got atypia, pagetoid spread, confluence. We've got atypical nests in the dermis embedded within the regression right here. And sometimes when most of the lesion has regressed away, it's difficult or impossible to be sure if it was melanoma or not. Here, look at how much that looks like dysplastic nevus there. Scary, huh? So that's an important thing to be aware of, why we need to see the whole lesion too. So that is a melanoma with regression. This is a very dense kind of regression in this case. In earlier regression, the collagen is more loose and mixed with pigment incontinence and inflammation, but sometimes it kind of gets dense and burns out and gets very dense and sclerotic and almost morphea-like, if you will. Not really, but so
Right.
just know that regression sometimes is this dense, but sometimes it's not. Sometimes it's much looser and more inflamed and irregular. When it's dense like this, I think it becomes much more difficult to tell it apart from actual scar. Okay? Yep. There we go. Yeah, this is melanoma in situ. Well, actually, I think there was focal invasion in this one. I saw on the slide elsewhere. Lentigo maligna, and a good example that you get a lot of variability in lentigo maligna. Some areas will have single melanocytes that are atypical and scattered along. And we talk about confluence, but confluence is something that sounds good in theory, like that you should have a solid line of atypical melanocytes replacing the basal layer. In real life, it almost never is like a totally solid line, except maybe in acral lentiginous melanomas. They really get confluent sometimes. Lentigo malignans may, but a lot of times it's kind of a lot of single cells with way increased density greater than normal, even for sun damaged skin, but then areas that are more dense and then areas that are more sparse and that kind of skip around, and you have a variable amount of density throughout the epidermis. But the melanocyte then keeps going and going and going. Dr. Rapini, one of my favorite mentors, likes to say it's like the Energizer Bunny. It keeps going and going and going, and probably Energizer is going to come and like put a ban on this video, a copyright violation or something. We'll see. I guess I'll know I've made it then when Big Battery comes after me for using their terms. But they should go after Dr. Rapini first. Just kidding. Don't do that. Okay. So the other thing I wanted to point out is that you may or may not have nests. Okay. So sometimes lentigo malignans is totally composed of single cells. Other times it becomes more nested, and those cases are more obvious. Very big atypical. And then these are also, I find that lentigo malignans can this one doesn't, but some have really tend to have areas that look a lot like dysplastic nevus, which is why I always harp on the fact, don't call stuff moderate or severe dysplastic nevus on the face of an old sun damaged person. You will almost always be wrong. I have seen multiple times where people have called things dysplastic nevus on the face of an old sun damaged person, and then it gets excised, or sometimes it doesn't get excised, and then later it's clearly melanoma, and it was melanoma the whole time. Okay, so dysplastic nevi do not often occur on the face. Even in people that get a lot of dysplastic nevi, I don't see them on the face very often in my experience. So, but be particularly careful in old sun damaged people on the head and neck to be very cautious, and think very carefully before calling something a dysplastic nevus. That's just my opinion. I would say on the sun damaged shoulders and arms of older people, I see dysplastic nevi often, but I still obviously use caution there, but that doesn't bother me really. But on the face, I'm really hesitant to do that. But big atypical cells, nests, single cells, and then oftentimes you'll have extension down adnexal structures. I think we may have that here. On a small biopsy, these can be quite challenging sometimes because you can have areas that have overlap with like the reactive solar-induced melanocytic hyperplasia that we see in older sun-damaged people on their skin, where they get increased density of atypical solitary melanocytes, and it's a significant daily challenge in our practice to tell that apart from melanoma in situ. In cases like this, there's no problem, no stains needed here. This is a slam dunk diagnosis of lentigo maligna type melanoma, probably a little bit of dermal invasion, a few areas where there's nests in the dermis. All right, 9. Yeah. Yeah, very good. And I don't know if in the past, people I think theorized that this had something to do an artifact from injecting the lidocaine. I think that most people do not agree with that theory anymore, but I don't think that it's still clear. I wrote actually a small paper about this a long time ago, but it's still, to me, I don't think it has been resolved exactly why this happens. And it doesn't matter. This is a totally just a, I would sign this out as benign melanocytic nevus. If you want, you could say it as congenital pattern, because it kind of trickles down between the collagen, but if you like. But the main reason this is just if you're starting out in Dermpath and haven't seen this, this could be confusing. You'll think, what is going on? Is this like is this like a hobnail hemangioma or something, or some atypical vascular thing? I don't know what this is and why is it present with the nevus. It's just a pattern we see. It's actually quite common. I see focal areas of it almost every day. I mean, really. And so sometimes though it can be very pronounced and really resemble vascular spaces, but it's just a benign nevus. And as is often the case in these kind of thicker congenital pattern nevi, there are multinucleated melanocytes, and sometimes from low power, those overlapping nuclei can look like a hyperchromatic pleomorphic atypical cell, but they're actually just multinucleation. It's just a trick. Don't be afraid. And you often have solitary larger melanocytes in the junction over these thicker congenital pattern nevi. Nothing concerning about that at all. See, like right there, how that looks kind of atypical from low power, but when we zoom in, they're just multinucleation. It's a little hard to see on this scan, but I know you guys have been doing Dermpath a while. This is like boring old news for you, but when you're just starting out, even these kind of simple things can be tricky. We got a little scratch in the cover slip there. More of that pseudovascular arrangement. 10, we don't have a corresponding H&E here. So I don't know if anyone figure this out? This stain is P16, I'll tell you that, because it's there on the label. Well, is this good or bad that we have P16 staining here? Good. Yeah, exactly. So P16 is a stain that has a lot of different things it can stain and a lot of different roles depending on the context. Okay. So, so like for example, it strongly stains HPV-driven squamous dysplasia, like HSIL or squamous situ in the anogenital region from high-risk HPV and invasive squamous cell carcinomas that arise from those. So in that case, I guess it's kind of bad, or it's a marker to help us detect that. But here in melanocytic lesions, the presence of P16 is normal and good, and either diffuse staining like this or patchy staining, both of those are considered normal. If you have diffuse significant loss of P16 expression in a melanocytic lesion, that doesn't necessarily mean it's malignant, but that is a worrisome sign that there may be an abnormality in the underlying cell cycle pathway because P16 is a protein that is linked to the gene CDKN2A. And so abnormalities in that pathway can be seen in melanomas. So when we have loss of P16, oftentimes that will worry us, depending on what the morphologic features are like, of course, and that may encourage us to do further testing like molecular workup in a melanocytic lesion. So in this case, this was a Spitz nevus, a benign normal Spitz nevus, and you can kind of see a glimpse of the large Spitzoid melanocytes looking like eyeballs staring back at us with their big central nucleoli, and they're kind of plump epithelioid to spindle cells. So even though we can't really see the cells well because of the staining here, that's what's going on is a Spitz nevus, and it's got kind of tracking along a hair follicle there, and it's normal that there's P16 expression. Mm-hmm. Very nice. Very good. I think that what you just said can be quite tricky to figure out at first, to recognize that what we have here are melanocytes, these bigger plump cells, and then the small dark cells are the lymphocytes. And sometimes, because as you guys know, in nevi, sometimes the nevus cells, the type B nevus cells, as some people call them, are lymphocyte-like. They're small and dark and round. They, at close look, they do actually look different from lymphocytes, but at lower power, they can look very similar to lymphocytes. Here, the cells are more kind of the plump epithelioid type A melanocytes, so they look plumper. Though you could have a really hard time telling these apart from histiocytes. If you just showed me this picture, I honestly would have probably thought these were histiocytes if I didn't know anything else and just had this picture and you said, what are these? I'd probably say it's like lymphocytes and histiocytes. So it can be quite hard to tell at first unless you begin to see nests. And in this case, I think there is some nesting in here. Some of these probably are histiocytes too, but there are melanocytes in there. And then also if you go out to the periphery of the lesion, you can sometimes see, maybe it's the other side, you can see the melanocyte nesting a little better. There it is. See the nests there? So yeah, when you get a nevus that has a dense mixed in lymphocytes, that is, I would probably just sign this out as a nevus with brisk inflammation, but based on the clinical, oftentimes nevi like this have a halo of depigmentation around them. So we call this halo nevus or halo nevus phenomenon. Usually though, like I said, I sign it out as nevus with brisk inflammation. And if you told me there was a halo, I would say that the brisk inflammation corresponds to the halo phenomenon seen clinically. All right, but when we're teaching, we just call this halo nevus. I will also point out we usually see these in kids or teenagers, young adults. I do get more worried in an older patient if I see a lot of inflammation in a melanocytic lesion. It doesn't necessarily mean it's malignant, but it means I'm going to stop and look closer. In younger people, though, this is pretty common. And a couple things, one that my mentor, Doug Parker, pointed out to me, that the inflammation is very dense and it's very even, right? It's evenly distributed here, not really patchy. And there's not, for some reason, there's not much fibrosis with it. So even though nevi can regress, when we see halo nevi, they don't seem to result in that dense regression-like scar-like collagen. So at least the ones that I've seen. So if we saw patchy inflammation and regression-like areas, that may make us stop and get more concerned here. Okay. And then the other thing, oh, here you can see some nests of melanocytes in here a little better. These are better melanocytes up here. The other thing I'll point out is that these, maybe it's just because these are often in younger patients, but I feel like almost always when I see halo nevi, they have plump cells. They often have bridging. They often, if you would take the inflammation away, they look almost like a moderately atypical dysplastic nevus, I guess, if you're into that sort of thing. Some people don't grade dysplastic nevi for understandable reasons, but that's way outside the scope of what we're talking about today. So to me, if I see moderate kind of plump atypia in these, I do not worry about that at all. I feel like that is, I don't know if the inflammation causes that or if it's because they're young people and young people usually have kind of larger melanocytes in their nevi. I'm not sure what it is, but I would say that it's a feature that's almost always present. Oh, look, and there's one mitosis. Well, that's okay. For one thing, I don't know if that mitosis is an inflammatory cell or a melanocyte. And even still, we see a single mitosis in nevi regularly, honestly, if you look really carefully. There have been studies that say that if you look at a bunch of nevi and carefully study them, you'll find a mitosis in I think it's like 25 or maybe even 30%. So it's one mitosis does not make melanoma, okay? Halo nevus. Oh, and if you do like a MART1 or an immunostain, it can make it much more obvious that there's a nice structured, organized melanocytic lesion hiding in all this inflammation. It's kind of hard to evaluate, architecture when it's also dense, right? So if you need, you can do a stain to see the melanocytes better. Case 12. Yeah, very nice. We have plump atypical cells forming nests and solitary cells that are filling and scattering all the way up to the top of the epidermis. They have pale cytoplasm. They are making an eyeliner sign down here, but it's kind of a squished, thin eyeliner sign or crushed eyeliner sign. Like right here, look, you can see there's a little line underneath, but they are so compressed as opposed to kind of the more thick eyeliner sign that you see like in squamous cell carcinoma in situ, Bowen's disease, right? The other thing is that Bowen's disease usually will have some areas that are full thickness, complete filling of the epidermis by atypical cells, and you almost never see that in Paget's or in melanoma. So melanoma usually does not make an eyeliner, so that would be one clue to tell you that this is probably Paget's, not melanoma. The other clue is that we're on the nipple. There's the big bundles of smooth muscle there that you see in the nipple and the areola. So in that site, it's something that looks like this is Paget's unless proven otherwise. I mean, you could have a melanoma on the nipple, but you would never make that diagnosis, I think, without stains or like obvious, I guess with stains. And do note that rarely Paget's of the nipple can express SOX10. Dr. Michelle Pitch, our former fellow and now colleague, presented a very scary case of that at the ASDP meeting last year. So in this case, so just beware of that. So what I would do here is probably like CK7, which is my favorite stain for Paget's, both extramammary and mammary Paget's. There are rare times where Paget's is negative for CK7, like in the perianal area, it can sometimes be CK20 positive. But CK7 is the one I like, or you could use another low molecular weight like CAM 5.2. I don't use GCDFP 15 or mammoglobin. That's kind of like dirty or non-specific, kind of old school immunostain. In my opinion, I don't find those stains very helpful. But you could use CK7. Also, HER2 new immunostain stains like essentially from a recent lecture I went to, basically all cases of Paget's of the nipple are essentially always positive for HER2, which I was not aware of, but that's what one breast pathologist said at a meeting I went to not long ago. So I have only done that like maybe once and it worked beautifully. So if you need to, you can do HER2. And of course, Paget's of the nipple is they have to work up to rule out underlying invasive or in situ breast cancer. So there has to be concern for that. And always check the dermis to see if there's invasion, because Paget's, both nipple and extramammary Paget's, can have invasion of the actual dermis from the in situ stuff. Sometimes you can see mucin in the cells. You can do a mucicarmine stain to highlight that if you like. Sometimes you can see like little droplets of blue mucin. We kind of can get a hint of it here, but it's not great. And sometimes you can actually see lumen formation, little gland formation. Oh wait, there it is, one right here. See, there's a little globule of mucin production inside this tumor cell. So that's Paget's disease. And I have other videos and examples of that online. Okay, 13. Mm-hmm. Yeah, blue nevus. I like that you pointed out the dense sclerosis in the background. Blue nevi usually have dense collagen in the background that's denser than the background dermis. It's a very nice diagnostic clue. Sometimes they have a lot of pigment, sometimes they have almost none, so-called amelanotic blue nevus or hypopigmented, non-pigmented blue nevus. I would say though that almost always, if you look around, you'll find tiny bits of melanin pigment, even in the ones that have very low pigment. There's usually some pigment present. The pigment is present both in dendritic, spindly, elongated melanocytes in their cytoplasm, and also in background, kind of larger, chunkier melanophages. So you get both of those. And it can have a range of cellularity from being very sparse, kind of sclerotic and hypocellular, to being a little bit more cellular like this. And sometimes they're, kind of, this is not really that large, but it's larger than some that we see are really tiny, like in everyday practice. But this is totally like fine. It's a normal blue nevus. Here, I like this case that if we got to the edge on this second piece, it looks a little bit different. There's like more pigment here. So this would also be fine. If you just had this, blue nevus still. A lot of the ones we see in practice are little tiny things like this. But you can see ones like this and much bigger and even more cellular than this. So it's got to be quite a bit more cellular and deep for me to call it a cellular blue nevus. And they do both cellular and regular blues. They will sometimes track along adnexa like that, track down a little bit along hair follicles and wrap around them. It's pretty normal to see that. Oh, and the last thing, blue nevi usually have collagen trapping. So if you take the pigment away, a blue nevus looks a lot like a dermatofibroma. The difference, I think, is the cells in dermatofibroma are often a little bit more plump, and you often get epidermal hyperplasia, which you don't usually have in blue nevi. And the pigment, if you have pigment in a dermatofibroma, it's going to be hemosiderin pigment, and in a blue nevus, it's melanin pigment. 14. Yeah, good. Yeah, very good. So like a pigmented patch or kind of pigmented grayish to bluish patch in the shoulder for nevus of Ito, and then around the eye, cheek area for nevus of Ota. And then I think you guys can correct me if I'm wrong, but I think that's if they're present since childhood. And then if they're acquired, it's what, nevus of Sun and nevus of Hori. Am I right about that? Got to be eponyms for everything. Okay. Uh, so but I think that as a broad group, these are dermal melanocytosis, scattered pigmented spindled or dendritic melanocytes with a very low cellularity in the dermis. It's the same thing we see on the lower back of children, what was formerly called Mongolian spot, but dermal melanocytosis is I think the more proper current usage for that. But this is in that same category of dermal melanocytosis. It's just the difference is based on the site. Yeah, if you had a small lesion of it, you could wonder, is it a really subtle blue nevus? And again, I like that you brought up, Raheel, the lack of the sclerotic stroma and also the clinical to tell that apart. The other thing that you could think about here is this just melanin pigment incontinence, right? So it'd be really hard if you just had a small shave of that to tell. One thing is that these are a little bit more spindled and have like pigment in the elongated cytoplasm. I find that helpful for any dermal melanocytosis or even blue nevus. Elongated cytoplasm with fine, delicate melanin pigment, that's pretty good. Like that cell probably is a melanocyte, not a melanophage. And that's a good, that type of cell we usually see in blue nevi and also in dermal melanocytosis, including nevus of Oda and Ito. And the other thing you could do is actually melanocytic marker like MART1 with a, you would want to use a red chromogen here because it'd be hard to interpret otherwise, or SOX10 to prove that these are actually melanocytes rather than melanophages. I mean, there will be melanophages here, but you want to prove that there's scattered melanocytes in the dermis to prove that that's what's going on here. So these can be, this one's got a lot of pigment. I've seen ones that are much more subtle and sparse than this, and you have to really kind of hunt around and know that what they're looking for clinically sometimes to arrive at the diagnosis. Very nice low power. Yeah, very good. Yeah, just regular nevus, right? And then this looks different. Very good. Yeah, wedge shape from low power. What the other way I like to think of that is like upside down pyramid or upside down triangle pointing down means it's wider at the top, gets narrower towards the bottom. I'm trying to zoom out here. It's taking its time. And like all things in pathology, when we describe what things look like, you have to use a lot of imagination, right? But it's kind of like a, pointing down to the bottom. And that's the reason for that is because it often does track along adnexa, like hair follicles, just like you said, leaping. And so this is a deep penetrating nevus. You will find in books, sometimes people use the term deep penetrating nevus for things that I would call a cellular blue nevus or vice versa. In real life, I have seen some cases where I struggled, but I feel like people kind of use these terms interchangeably, but they are different things from a molecular basis. Cellular blue nevi have genetic abnormalities of GNAQ or GNA11 mutations. And then deep penetrating nevi, or the newer name that people have proposed is deep penetrating melanocytoma, because molecularly they have two molecular abnormalities, which, so what happens is, and things with two molecular abnormalities are often put into the melanocytoma category. It's kind of in this stepwise progression. These still behave in a benign fashion. There are rare examples of melanoma that are a deep penetrating nevus-like, but most of the time when we see deep penetrating nevus / melanocytoma, they have indolent behavior, but oftentimes people do like to excise them completely. I think that's reasonable. If nothing else, if this thing recurred, it's going to look really scary, right? Because it already looks kind of atypical compared to a normal nevus. These basically what happens is they are, the vast majority of times when I see deep penetrating nevus, it is present with a regular conventional nevus component. And the reason for that is because what happens is that these usually start out as a regular nevus, usually driven by a mutation in the MAP kinase pathway like BRAF or other tyrosine kinase. And that starts, they have a nevus that's driven by, that's going to be like BRAF positive. And then one of the cells gets a second hit, an abnormality of beta-catenin. And the beta-catenin mutation then produces the deep penetrating component. So you have sometimes you can just see a tiny focal area of this in the background of an otherwise normal nevus. Other times, the majority of the lesion is filled with a deep penetrating component and just has a little bit of that nevus left. So almost always, I would say when I encounter these, they are a combined lesion, meaning that there's two different components, a regular nevus and then the DPN, deep penetrating melanocytoma component. Kind of analogous to how we see that process happen in BAP, inactivated melanocytomas, where you have a tyrosine kinase driven nevus, and then the BAP1 loss happens, and then that component grows in the middle. So it's that same kind of combined concept. Okay. So the morphology though, so the presence of a normal nevus plus this is a great clue for deep penetrating rather than cellular blue. Whereas like in cellular blues, like I mentioned, you can go up to the top and look out to the side and you'll find regular blue nevus usually. The other thing is that the cells are a lot more plump than blue nevus usually, and they're arranged in kind of nest, like elongated nest / fascicles, nesticles if you like. I don't know. And then those kind of are elongated and sometimes a little serpiginous and kind of go intercalate between the dermal collagen bundles. The cells are plump, have a plump spindled nuclei with a usually abundant cytoplasm. The cytoplasm is pale, kind of gray, often with kind of powdery melanin in it. And then in the background, you have much darker, denser pigment inside melanophages. So the really dark cells are melanophages, and the kind of less dark cells are the plump melanocytes. And they kind of have in the past, some people have described something, a plexiform spindle cell nevus, which I think probably many of those are actually just deep penetrating nevus, in my opinion. Other people might disagree. But so the plumpness of the cells, the arrangement in nests with abundant cytoplasm, and then the dense background melanophages, those and the wedge shape and the regular nevus next to it, those to me are all things for deep penetrating nevus slash melanocytoma as opposed to cellular blue. I've got another video about that. It's a little bit older, so it doesn't have some of the newer molecular things I just mentioned, but in any case, there you go. And beta-catenin. So if you do a beta-catenin stain, actually you'll see beta-catenin here, not just in the cytoplasm, but in the nucleus. Beta-catenin is present in the cytoplasm of many things, but that doesn't matter. Only nuclear staining, when we're talking about beta-catenin being positive in something, in general, nuclear staining is the only thing that matters. So it can be kind of challenging to interpret because the background cytoplasm makes it hard to tell, is the nucleus really staining or not? And then if there's a bunch of pigment in the cytoplasm, it makes it even more challenging. But it can be helpful. It's kind of pretty for teaching purposes. I'll have to pull a case out and upload it to show you guys. Okay, 17. Yeah, left is very different from the right. So here's the right. And then we've got nevus cells, right? Going way deep down. Yeah, and then we've got nice neurotization, right? Wagner-Meissner-like bodies, tactoid bodies, Masson bodies, whatever you want to call them. And then all the way down into the fat. So probably a true congenital nevus present since birth, and probably a very large one, right? Given that we've got a big chunk of it here, and yet clearly it's broadly transected. And then what's going on over here, Kayla? Yeah. Yeah, exactly. We've got really atypical melanocytes with pagetoid spread, confluence, consumption of the epidermis, lots of pagetoid, and they're much more atypical down here too compared to the background. There would be mitoses, I'm sure, in here. I didn't look carefully for a long time, but in a melanoma this large and deep. So this is a large invasive melanoma arising in a large congenital nevus, which we know people with large congenital nevi have a significant risk of developing melanoma. I mean, it is a minority of patients, but it's a very real risk of developing melanomas. And the melanomas in large congenital nevi often develop when patients are young still, which is problematic. And sometimes they can develop down deep in the lesion as like a nodule. The one thing I would caution you is that all to know is that here we're helped by the fact that we've got obvious melanoma in the epidermis. But sometimes when you can get a big cellular and mitotically active nodular area in a large congenital nevus, and that it can be benign, and it's called a proliferative nodule. I still find those very scary, and I am not comfortable with them. And the rare times I've encountered them in practice, I've sent them out to melanocytic experts because I know there's a lot of stuff published about it, but it's quite nuanced in my opinion. So I think they're quite scary, and I know a fair number of other dermatopathologists I've talked to feel the same. So I really, and they're usually big, deep, and in kids. That's stuff that I want to make sure an expert has seen. But here, I think there's no doubt this is melanoma. I don't know how old the patient was or the history here, but this is melanoma arising in a large, probably a giant congenital nevus. I don't know if it was like bathing trunk or not, but it's clearly a very large one. Very unfortunate. Case 18. Yeah, good. Dispersing but not maturing. It's like pseudo maturation, right? It looks like it's trickling at the bottom, which is good, but the cells are the same size at the top and the bottom. Very good. So what do you think's going on here? Very good. Metastatic melanoma. And you're right, in some areas, if you don't see pigment, I mean, breast cancer could look like this, for example, right? Like lobular breast carcinoma. But once we start getting nice nests and melanin pigment, we could feel, pretty confident these are melanocytes. But if there's any doubt, I, do a stain because you're about to give someone stage 3 or stage 4 melanoma, depending on the clinical context, right? Sometimes, so this is when you get a nodule of melanoma in the dermis, and they often push up towards the epidermis like this, and sometimes can even get like a collarette almost, which you're kind of starting to see here. That's good for a metastasis of melanoma. It could be a metastasis from a distant site, or this could represent a satellite lesion or an in-transit metastasis somewhere between the primary melanoma and the lymph node. You have to know, based on this, I have to know when and where did they have the melanoma to know, is this a distant met or a satellite or an in-transit? And that will, depending on the answer to that, it will affect the staging. So you have to have some clinical info to tell those apart. I think the one other thing you could consider here would be a nevoid melanoma, because it kind of has pseudo maturation. Usually a nevoid melanoma will have melanoma in situ component with it though. And even though metastatic melanomas are in the dermis, sometimes they can trickle into the epidermis and mimic melanoma in situ, and those cases can be really hard to tell apart from a primary melanoma. It can be tricky, but I do think that they often still retain this kind of nodular, kind of ball-like shape. And then also clinical history can be helpful. Luckily here, when we go to high power, I feel it's the true of metastatic melanoma, but also nevoid melanomas, that at high power, even though the cells might look a little nevoid from low power, these are very atypical up close. Huge nucleoli, pleomorphism, mitosis. So, and then when we go down to the deep, even the things that look like they wanted to mature, nah, they look bad, just like the ones at the top. So I find that helpful for nevoid melanomas also, that you've got atypical cells and they're atypical all the way down in general. So that can be helpful. And the clinical history, of course, being very important. So this metastatic melanoma, and then also look, another clue, lymphovascular invasion here with a little additional little tiny focus of metastasis in the dermis, and one probably inside a lymphatic, or this could be right next to a lymphatic actually, because it could be an endothelial cell there. I'm not sure, but it actually could be outside the lymphatic, but metastatic melanoma. 19. Okay, what's this? Yeah, these are Spitzoid, and evaluating Spitzoid melanocytic lesions is challenging because they look atypical, right? They've got large cells, large nuclei, prominent nucleoli, big nests a lot of times. They can have some mitoses. So Spitz nevi can be, if you don't recognize them as a Spitz, they can look like a melanoma at first glance. And remember that originally that's what they were described as by Sophie Spitz, as childhood melanoma. Even then, though, recognizing that they had a different behavior than adults, and it was not long later that it was realized that these really are nevi. Of course, we now know that there are atypical forms and melanocytomas and also Spitzoid melanomas, and it's complicated way beyond what we have time for. But plump epithelioid to spindled melanocytes, sometimes they involve the epidermis, sometimes the dermis, sometimes both. So you can have junctional, intradermal, or combined, I'm sorry, or compound, excuse me, pattern Spitz nevi. Of course, I want to know some clinical, the age of the patient, what this looks like, all that stuff, okay? But microscopically to me, I'm actually okay with this being a Spitz nevus, unless this is like an old sun damaged patient. There's no solar elastosis here. But older patients can get Spitz nevi, but I am much more careful and I am much more demanding in the criteria the older a patient gets. Some people, I don't know if they all, not if everyone agrees with that view, but that's the way I do it. So in any case here, I would say the cells look kind of atypical, but they all look kind of alike. So that's what my mentor, Doug Parker, said. They look funny, but they all look kind of the same sort of funny. They look the same sort of atypia throughout, you know. If you start seeing a lot of pleomorphism, lots of mitoses, atypical mitotic figures, deep mitoses, asymmetry from the left to the right, those are features that, and there are others, and people debate about this, but those are features that get me worried about a Spitzoid lesion. And in practice, these are hard, and whenever I see these, I usually show them to my colleagues just to get make sure that we're all in agreement and have consensus about it. Okay, and I kind of wonder with these elongated, almost fascicles, I wonder if this one might be like an ALK positive. There are lots of different types of gene fusions that can be seen in Spitz nevi, and different molecular subsets of Spitz that have been described in recent years. Right. So Spitz nevus, and in practice, these are a struggle. for us sometimes too. This one's particularly inflamed, and there is some dense collagen in the background. As you can sometimes have a lot more than this, and you can have even like desmoplastic kind of change. I don't really like that term because it sounds scary. I like to say sclerotic nevus or sclerotic Spitz nevus personally, but a lot of other smarter people than me say desmoplastic. I just think it sounds scarier than it needs to, but this is a Spitz nevus. Here's the low power shape, and then high power. Yeah, good. It's a combined nevus. And so when we say combined nevus, we usually say what components are present. So I'd say combined nevus with a conventional nevus, banal nevus, whatever name you want to call that, congenital pattern nevus. And to me, I would call this deep penetrating nevus or deep penetrating melanocytoma because we got plump kind of epithelioid to spindled cells with abundant grayish cytoplasm with some fine melanin pigment. And they're making these kind of elongated nests between the collagen. And then we've got these really darkly pigmented melanophages scattered in the background. And it's again arising in the context of a pre-existing conventional nevus, so that's going to probably be BRAF or other tyrosine kinase driven, and then beta-catenin added on top of it in these here. So similar to that one we saw previously, I think the cytology in this case actually even more kind of classic to me for a deep penetrating nevus. And you can see even though it's not quite as wedge shaped as the previous case, it kind of is, right? If you use an imagination, you can kind of see that it kind of points down like to right here at these erector pili. So again, you have to really use your imagination though. And it is tracking kind of along a nexus. So combined nevus and deep penetrating nevus / melanocytoma. 21. Yeah, it is a congenital nevus, and the reason that it looks slightly concerning, I mean, it's a poor quality scan, but it's because it's so dark, right? And so earlier I was mentioning that sometimes melanocytes can have like a small round blue kind of look and like a lymphocyte-like pattern. So those are going to look darker from low power. Sometimes that can be concerning because of the hyperchromasia from low power. Sometimes they can look like inflammation. So those are just type B melanocytes, if you like that kind of old school way of talking about them. Type A for being the epithelioid ones, which we kind of have here. Type B being the lymphocyte-like ones. Type C being the spindly ones. And you can see any or all of those in nevi. The key here, in the epidermis, we have some little nests and single cells down reedy, but we don't have pagetoid or confluence. So that's good. And then we don't have any significant cytologic atypia. We do have those multinucleated cells that can look scary. And on this scan, you can't tell they're multinucleated, but with practice, you can like recognize them right away. It's just a trick like that. See, it's a kind of cluster of nuclei, totally fine. And we see that in congenital pattern nevi particularly. And then we have tracking along adnexal structures and scattering and intercalating between the collagen. So this trickling pattern between collagen by nevus cells is a very reassuring, benign pattern, although sometimes melanomas can do it, like we saw in that case of metastatic melanoma earlier, but generally I like when nevi do this at the bottom, trickling between collagen. And it's weird because it's the exact opposite of the way that epithelial cells should grow, right? Epithelial cells trickling between stuff, we call that infiltrative growth, and we say it's an invasive cancer. But melanocytes, it's totally fine. The rules are different for melanocytic lesions, which is part of why they're hard. They are very different rules from the way we evaluate a lot of other tumors in pathology. So tracking along hair follicles, tracking along neurovascular bundles around eccrine coils, it is totally normal to have wrapping of nerves. So do not call this perineural invasion. This is not a malignant finding in nevi. Nevi track along nerves all the time, particularly congenital pattern nevi. I do not personally use that as a criteria for benign versus malignant in melanocytic lesions. Once you decide something's a melanoma, tracking along a nerve then becomes perineural invasion. But otherwise, I don't use, oh, there's nerve, because I see this like almost every day in congenital pattern nevi. So it's totally normal. If you look for it, you'll find it all the time. Tracking down around hair follicles. Also in one of the most like real, sometimes the things have some congenital features, but maybe were not present at birth. So that's why a lot of times we call things congenital pattern nevus, because, regular nevi can have some overlap. Acquired nevi that you get later in life can have overlap and some congenital pattern to them, even though they were not truly congenital and present at birth. So it doesn't really matter. But sometimes when these are larger, some of the features can be kind of weird if you've not seen it before, like tracking along nerves or going deep down along hair follicles, or having these multinucleated cells here that look hyperchromatic. It's common for nevi, particularly congenital pattern ones, to bulge into and push into the lumen of lymphatics, and it looks like lymphovascular invasion. Do not be afraid of that. It's totally fine. There was one thing I was trying to find. I don't know, maybe we don't have it here. Is trickling of nevus cells into erector pili muscles. Supposedly that is the most like specific finding for a true congenital nevus. It's like the nevus cells formed with the erector pili as it was growing, in the developing fetus or at the embryo stage. I thought, yes, I was gonna say, I thought this one had it. It's not the most perfect example, but see, erector pili with little melanocytes trickling into it. That's like a really classic. Here, there's more right there. Erector pili with nevus cells. That's a classic congenital pattern. And then look, another nerve and vessel wrapped by nevus. Congenital nevus. This is a nice case. 22. Yes. So what's this one? Yep, it's a nevus. It's got rounded melanocytes at the top with some nests. And down here, a lot of those spindled type C melanocytes that kind of look neurotized, right? Like neural-like with Wagner-Meissner-like or tactoid bodies. Good. And then what's this over here? Yeah, they're not easy to see on this scan, but there are a few in there. Yeah, very good. This is an actual neurofibroma here. And this is a nevus over here. So it's nice that we got two in the same thing. And clinically, these often look like fleshy skin-colored papule, right? Or tag-like structure. So often these will come in with the differential of nevus versus tag versus neurofibroma. Those three things look alike clinically, right? So it doesn't really matter because they're both benign, but sometimes people ask, well, how do I know if it's a neurofibroma or just a neurotized nevus? It usually doesn't matter. They're both benign and would be treated the same. But to me, I think the easiest thing is that nevi can have areas that look identical to me, and I'm a soft tissue pathologist too, as you will be soon, Raheel. But to me, they look some areas identical to a neurofibroma, even with little nerve structures in them. But to me, that usually the best key is that you'll find if you go up to the top near that the superficial dermis, there will be some amount of more rounded melanocytes or nesting, like essentially always. Without those, I wouldn't know how to tell it apart. It would look the same as a neurofibroma, but I feel like those are almost essentially always present, even focally sometimes. But so that's just a benign nevus. It's got neurotized pattern, and then an actual neurofibroma over here. Yeah, very good. And note the background of the neurofibroma is very pale because it has a lot of like finer collagen and usually some myxoid ground substance in it. It's very subtle. So it's paler than the bright pink of the normal dermal collagen is replaced by this fine pale collagen in the neurofibroma. Good job. All right, 23. Yep, yep. Very, yeah, very good. This is good for desmoplastic melanoma. Probably the first thought at low power because you've got a spindle cell proliferation effacing the dermis that going down into the subcutis even with a prominent nodular lymphocyte aggregates. Look, it's going all the way down deep subcutis and it's still going all the way down to the fascia. And we still have atypical spindle cells there. So that's a classic growth pattern for desmoplastic melanoma. This one may have some slightly more plump cells in it that could actually be a combined mixture of, oh no, maybe it's just cross-section of these spindle cells. And we do make a distinction between spindle cell melanoma, which is much more cellular and looks a lot like looks like AFX or like a sarcoma, and then desmoplastic melanoma, where the cells sometimes in this case they're kind of plump and obviously atypical, but sometimes the atypia is more subtle. They can be like very neural looking, but the cells are divided from each other by intervening collagen, often with a bit of bluish myxoid background. Lymphocyte aggregates, if you have a big enough sample, almost always present, although on a small shave biopsy, these, especially subtle cases, can be extremely difficult to diagnose. Thankfully, this one has very, very obvious atypia once we look around. And again, you may have to hunt around for a while, but usually you will find mitoses. And if you have a big enough sample, perineural invasion is usually present. Desmoplastic melanomas love to have invasion around nerves. Like this right here is probably a big nerve that has been replaced. I don't know 100% for sure, but it really is suspicious for that. So nerve involvement and replacement. This area is getting more cellular and almost to the cellularity, closely approaching a spindle cell melanoma, but most of this is hypocellular and desmoplastic melanoma. Most of the time we see these on the head and neck of older sun damage patients, but I think this one looks like it's on the trunk, and so sometimes you can see them in other contexts. They may or may not have a melanoma in situ component. If you're lucky and you get that, that's a very helpful clue to the diagnosis, but about half of cases lack an in situ component, and they pure desmoplastic melanomas, when greater than 90% of the tumor is made of this hypocellular desmoplastic component, they usually, if they don't have an in situ component, they usually will not have pigment production, which is how you can tell them apart from, say, blue nevus variants. Plus, they're more atypical. But they can be really hard because clinically they can look like a scar. Microscopically, they can look like a scar or a reactive process. Very difficult. I have many videos and cases posted online about desmoplastic melanoma. It's one of the more challenging diagnoses to make, I think, in spindle cell dermatopathology. And a pure desmoplastic melanoma will just stain with S100 and SOX10, just like a nerve sheath tumor would, which further complicates them. They will be negative for MART1, negative for HMB45, because they're kind of more primitive, like it's like almost they've reverted back towards their neural crest origin. They look neural, they stain more neural, very difficult. And when they're pure, they have a lower risk on a depth by depth basis. They seem to have a somewhat better behavior than conventional epithelioid melanomas or more cellular spindle cell melanomas. They have a tendency for local recurrence, but less tendency for metastasis. It's still a serious diagnosis, but somewhat better prognosis on compared to other melanomas of the same Breslow. Unfortunately, though, these are often, by the time they're diagnosed, 10, 15, 20 millimeters thick, all the way down to fascia, which is a bad problem. 24. I'm not sure what the trick is here. Maybe just to trick you, since it's supposed to be a melanocytic lecture, to see if you would think this is melanocytic. But yeah, little nested here. Yeah, sure. Because I mean, epithelial things nest too, so that's fine. Yeah, that's exactly what I would call it, Kayla. I'd call it squamous cell carcinoma, and kind of uglier, I would probably call it moderate. Differentiation is somewhat in the eye of the beholder. Elsewhere in pathology, people might still call this well diff because it's obviously making keratin, but I would call it invasive squamous cell and probably say moderately differentiated, but I think there's some subjectivity there. Yeah, I think it's fair, though, to recognize squamous cell carcinoma seems easy, but I certainly have times, especially if you had a small sample, where you might struggle. And I have seen actual cases of melanoma that got misdiagnosed as squamous cell carcinoma, and stains weren't done. So, it seems like simple, but we can all make mistakes, and especially when we have a small sample or don't have a good clinical context, or if the cytoplasm is not quite as pink and looks a little more gray, you could have trouble. If you have any doubt, we can easily do stains to sort these out. CK56 or P40 would stain squam, and S100 SOX MART would stain melanoma. I think you could call this would be good for dysplastic. It's got dermal component. The junction goes beyond the dermal component, so we've got kind of shouldering. The nests have bridging between reedy. We've got some fibroplasia underneath. Of course, none of those individual things by themselves are specific for dysplastic nevus, which is part of the whole reason there's controversy over it for decades, because you can see some of those things in congenital pattern nevi and other nevus. But I think that plus cytologic atypia, and I think there's arguably obvious atypia here to my eye, at least. I guess it's in the eye of the beholder, but there are cells that are larger than like kind of the basal layer or mid-level spinous keratinocyte nuclei. You know, some people have used criteria about like using multiple times of the size of those as a way to judge how much atypia there is. But a lot of times I think in practice, many dermatopathologists use kind of a gestalt. So whether that's right or not, that's I think the reality, and which is why these are challenging and somewhat subjective. But I think this is fine for moderate atypia, although I would point out the caveat that the more recent WHO edition has encouraged us to use a low-grade, high-grade, two-tier system rather than three-tier. But I still personally, and maybe I'll get roasted for this, but I still use three-tier grading in my practice just because the dermatologists that I work with and have worked with are used to that. And so I think that it takes time to shift to a new system. And before making a shift, you got to really make sure that all of your treating physician colleagues understand and are on board. So I do think, though, that I like the idea of two-tier grading system. I do recognize there is some subjectivity in any grading system, and I do think that grading, it's hard to prove that grading necessarily matters or predicts what these lesions will do. And for anyone watching this online, that it's way more complicated than we can get into. But the basic idea is that dysplastic nevi, people with the syndrome that have the familial melanoma syndrome, get a lot of these atypical looking nevi with these sorts of microscopic features, and those patients have increased risk of melanoma. So a long time ago, people began to realize that you can see similar pattern of nevus in patients that don't have that syndrome, and so these were also called dysplastic nevi. And the concept has been challenged by others by saying, well, this is not really dysplasia. These tumors are not pre-malignant. They're not going to progress in a stepwise fashion to malignancy like we would think of in, say, squamous dysplasia. So I personally, in general, agree with that. Can a dysplastic nevus turn into melanoma? Sure, it can, but so can a congenital pattern nevus, or any nevus for that matter. In my personal practice, I feel like the most common times I see nevus come from, melanoma arise from a nevus is from just conventional nevus or congenital pattern regular nevi more than dysplastic nevi. But I guess it may be in the eye of the beholder. So yeah, I would call this moderate, and there has been some growing evidence. I think most of the derms I've worked with over my career have re-excised moderate dysplastic nevi if they go to a visible margin. There has been some more recently published literature suggesting that that's not necessarily required. So some people have different views about this. So basically, everything I've said, I'm sure there's someone watching this video who will disagree with something I've said. You are not alone. Everyone's been disagreeing about this since around the time that I was born, and it's probably not going to be resolved anytime soon. It's an area of great contention. I would say if you happen to be a patient watching this, recognize that dysplastic nevus is basically in general, these are benign nevi that are atypical or weird looking microscopically, sometimes because of, depending on the degree of weirdness and unusualness, your dermatologist may want to remove the lesion. And again, there is debate over that, and you can talk about it with your dermatologist. But please know that most of these lesions do not progress to melanoma. Okay, that again, talk about all this with your dermatologist. But I do see patients sometimes that watch these videos, and also patients that have been told by people who don't really understand the situation, oftentimes by non-dermatologists who may be less familiar with the complexity of this, that this is dysplasia, so it's a pre-malignant lesion, and that I think is not an accurate statement in general. As a broad thing, to say that a dysplastic nevus is a pre-malignant lesion, I don't think is accurate in general. Some of them could potentially turn to melanoma, but that's true of any nevus, and it's not feasible to remove every nevus from someone. So there you go. There's your philosophy for the day, and feel free to roast me in the comments below. I can take it, I think. But yeah, to me, I think this would be fine to call a moderate dysplastic. I do think once we're in the severe category, it's a good idea to make sure they're removed, because, at that range, we start to have overlapping features with melanoma, and, we're only human, and melanocytic lesions are hard. And so sometimes lesions that look like severe dysplastic nevus melanoma can mimic those. And so probably to be on the safe side, removal is a good idea to be safe. Moderate, I think it's still up in the air and an evolving area. Here's 26. This is a huge nodule, obviously cellular with pockets of necrosis. So my mentor, Dr. Rowe, one of my greatest mentors, said one of his tricks and clues for beginners in pathology is if you have a neoplasm that is hypercellular and has necrosis, it's malignant until proven otherwise. 99.9% of the time be malignant. There are rare exceptions, of course, but and of course, at higher power, we can see obvious cytologic features, nuclear features of malignancy, pleomorphism, nuclear enlargement, huge nucleoli, mitotic figures, pleomorphic, very large nuclei, variable size of the nuclei. I'm sure we can find atypical mitotic figures if we look around. So a very ugly, nasty looking tumor. And it's kind of epithelioid in some areas, a little more plump spindle in others. I think right away, always, if you see malignant tumor with overlapping epithelioid and spindled features, melanoma is in the skin. Melanoma is the first thing on my list. Elsewhere in the body, I still would put melanoma on my list, like a metastatic melanoma, because it has this tendency to overlap between epithelioid look and spindled. And then we can see here that there is nesting. So that's another good feature for melanoma, but like we just talked about, carcinomas nest also. So a poorly differentiated carcinoma could potentially mimic this. It'd be unusual to have this pattern, but if you have any doubt, do a stain, do a SOX10 or a MART1 or S100. If you see obvious pigment and melanoma in situ component, well, I think you've got your answer. To me, I feel pretty comfortable in that. But the reason I would say that is if you have any doubt, melanoma versus maybe a carcinoma, a melanoma of this size is a very serious problem and a high risk that the patient will develop metastases and die from this. So it is a very serious life-changing diagnosis you're giving someone to give someone a nodular melanoma with a Breslow of, whatever that is, 10 plus millimeters probably, I don't know, 8 or 10 millimeters maybe. So here, sometimes in these big nodular melanomas, they grow quickly and bulge up from the skin. And you can see it's kind of weird. It's super thick, but look, it doesn't really go much deeper than the normal epidermis next to it. And this is common, these polypoid melanomas that are nodular that get ulcerated on the surface and that look clinically sometimes amelanotic or look like pyogenic granulomas clinically. That's why always, I think, in my opinion, a pyogenic granuloma or something apparently pyogenic granuloma clinically, in my opinion, should always be biopsied, because amelanotic melanoma that's ulcerated can look identical clinically. So to me, I feel like anything that looks like a PG that's not ever been sampled should receive a biopsy. That's my viewpoint. So these lesions can be really thick, but sometimes still confined to the dermis. This one is going to the subcutis. But I find that over top, they can get really ulcerated or thinned out epidermis. Sometimes the epidermis, I think, erodes away, ulcerates, and then regrows a little bit. So the melanoma in situ component over the top is oftentimes lost. So you may not see any in situ and have to go out to the periphery to look for it, okay? And a true nodular melanoma, I think it was Dr. Clark, Wally Clark of a very famous dermpath, the one who invented Clark level and many other things that he published, was the one I think that said that to be a true nodular melanoma, the in situ component shouldn't go more than 3 reedy ridges beyond the dermal component. I'm not exactly sure here, but I guess it doesn't do that. But in real, so if there was, say, a superficial spreading out here beyond the edge, we would actually technically call it a superficial spreading melanoma, even though it has a large nodule in it. I kind of feel like this is it doesn't matter. It doesn't change anything for patient care. Melanoma, the thing that matters is the Breslow thickness much more than the subtype, really. The subtype is kind of a microscopic pattern for pathologists that generally doesn't matter clinically, with the exception of maybe Lentigo maligna, because they often extend way beyond and need wider margins to clear. But otherwise, I think most of the published literature supports that the subtypes of melanoma, based on their old school patterns, nodular, superficial spreading, Lentigo malignant, doesn't change their prognosis. The depth of invasion does, the thickness. All right, so obvious ugly cells there. And melanoma in situ here with pagetoid spread and nests. So now we know this has got to be melanoma. You could still do a stain if you needed to, but that's a nodular melanoma. And don't forget to look at the whole specimen. It's easy to stop when you're looking at this big thing in the middle, but always look at the edge, because sometimes you will get other information. In this case, this is a microsatellite lesion. And a microsatellite, there used to be like a size criteria. I think that has been removed from the AJCC staging manual, but you have to have a growth of melanoma in the dermis. So it can't be like a intralymphatic or perineural focus. It has to be in the dermis itself, and it has to be obviously divided from the main melanoma by an area of normal dermis. Now this dermis has cellular elastosis, but by normal I mean not dermis that's inflamed and scarred or regression-like, because then it might actually be just an area that's been detached from the main melanoma by regression, right? So there needs to be, and also you need to, in my opinion, need to make sure that you're not dealing with a tangential cut. Sometimes big melanomas can grow in a complex fashion, and depending on the angle of the cut, you can have an area down deep that may connect up to the main melanoma, but just be deeper in the section and you just can't see it, or the next block over. The reason that we should be so very clear on all those rules, and I know you know all this, Caleb, I'm just belaboring it for the people on Kiko and YouTube who are watching this later, because I don't think I've really addressed this before. The reason is that a microsatellite lesion or a macrosatellite that you can see clinically, or an in-transit metastasis that's, I think, defined as more than 2 centimeters away from the primary, any of those things, they basically count as the equivalent of a lymph node, a metastatic melanoma in a lymph node for the purposes of staging. They count as an N score. And in fact, if you have a lymph node plus even one lymph node, I think, I always have to look these ends up to make sure I get the subtyping right, but a microsatellite or a macrosatellite or in-transit met plus a positive lymph node bumps you well beyond. A positive lymph node would be N1, and depending on the letter, the little letter would depend on some other features, but if you have a satellite plus a lymph node, it bumps you all the way up into N3, actually, I believe. So it's a significant jump to have a satellite. So for that reason, you want to make sure that if you call a satellite, you're sure it's a satellite, okay? This is definitely a microsatellite, no doubt about that. All right, so there you go. I think that I looked at that the other day. I think that I wasn't sure if that was actually a satellite, a microsatellite. I think it probably is. I thought maybe it could be floater at first, but it actually looks like it is in the tissue there. All right, so there we go, nodular melanoma with a microsatellite lesion. Oh, nightmare scenario, right? These are, for anyone who has not seen this kind of specimen before, all of these fragments of skin from a sun-damaged old person, because look, the dermis is totally blue because it's completely replaced by cellular elastosis. But these are multiple fragments, and the reason it's fragmented like this is this was curetted and removed with a sharp scraping curette. And the reason probably was that it was assumed to represent clinically maybe a seborrheic keratosis, they thought it was, and it was curetted out and then submitted for pathology. I'm thankful that it was submitted for pathology, but unfortunate that it was curetted because in a case like this, this ended up not being a seborrheic keratosis. This was melanoma. This is Lentigo maligna melanoma, where you can see confluent growth. This is actually a pretty good example of confluence. Atypical melanocytes replacing the basal layer as single cells, and there are nests in some areas. There's pagetoid spread here. Lentigo maligna sometimes don't have pagetoid spread. Sometimes they have none. Sometimes they have some. It just depends on the case. And then in other areas, you can see nesting. There's nests right here. Obvious atypia here. If you're just starting out, sometimes it can be hard to tell. Are these melanocytes or keratinocytes? The pale cytoplasm, I think, is really helpful. The pigmented cells here are actually mostly keratinocytes. I've got a video about melanocytes versus keratinocytes that has some tricks. That's a short video. You might find that helpful. You can go check that out on my Kiko index with the link down below. So this is why I would encourage anyone watching this, please don't curette pigmented lesions unless you're like 100% certain it's a seborrheic keratosis. I don't know. What do you think? Is there any time where curetting a seb that would you curette a seb? Is that okay if you're sure it's a seb? I think that's a very reasonable approach, and I can understand that some people, because there are sometimes that you look at a seborrheic keratosis and it's certainly one. But I will tell you that we all are frail humans and can make mistakes, and I have seen many very, very good, skilled dermatologists that really thought something would be a seborrheic keratosis or lentigo, and they biopsied it, appropriately biopsied it, and it ended up being melanoma, and they were shocked. And I've also seen times where they thought it would be a basal or something else and it was a melanoma, or they thought it'd be melanoma and it was something different. That's why I still have a job. It's not because those dermatologists aren't good. They were some of the best dermatologists I've worked with. Every dermatologist will have this problem and be tricked. Just like there are some specimens that pathologists know, no matter how good I am, I will always be afraid of that entity or that type of specimen because you can always be tricked by it, right? Medicine is hard, and lesions don't play by the rules sometimes, and we know that they can be tricky. So knowing that pigmented lesions can be melanoma, and knowing that even very good people, it's sometimes not possible to tell them apart, I do feel like it's probably safer to biopsy, not curette a pigmented lesion. I like that approach, but I can recognize that there may be other schools of thought on that. But I would not want a pigmented lesion curetted off of me or my family. I'll say that at least. So take that for what you will. Because the reason that this is a problem for anyone who hasn't put this together, in this case, it looks like most of this lesion is in situ, thankfully. But what if it were invasive melanoma? You would then have fragments, and how would we know how deep the invasion goes? Because none of these fragments are oriented in the normal way that we embed tissue, so that when we cut it, we can see perpendicular to the epidermis, right? Like a straight down cut through the skin, so we can see epidermis, dermis, subcutis in that order, and we can measure all of our derm path is based on that, with the exception maybe of alopecia biopsies. But that's how we measure Breslow thickness. So when you have a really tangential fragmented specimen like this, there's no way to give an accurate Breslow thickness. And Breslow thickness is how we predict the behavior of a melanoma, how we decide whether or not to do a lymph node biopsy or dissection. So this can create a really terrible situation if you curette out an invasive melanoma. And yet, in general, I would say anything, if you're a patient watching this or you're someone who's going to do biopsies, I don't think any tissue should go to the trash, with the exception maybe of skin tags that are obvious non-pigmented skin tags. And in general, I say like dermatologists, I feel actually uncomfortable with anyone but dermatologists doing that, because I have seen other people who have less familiarity with derm that have thought something would be a skin tag that was clearly not a skin tag, clinically or microscopically. Again, you can disagree with me if you like. I'm just telling you my opinion based on 11 years of derm path practice and seeing various things that have happened and mistakes that have been made along the way. Everyone makes mistakes. I'm not trying to be judgmental. I'm just trying to think about patient safety first. So if in doubt, do not throw tissue away. I have seen patients that came in that had a biopsy done. They thought it was something benign and they didn't send it to pathology. They threw it in the trash, and the patient came back with metastatic melanoma in their lymph node a year or so later. So guess what? That lesion was probably a melanoma. We'll never know for sure, will we? So, and I'm not saying I get paid salary. I'm not saying this so I get more specimens. I don't want more work. I got plenty of work, guys. So there you go. So there's our philosophy, patient safety lesson. And again, I'll probably get roasted in the comments, but patients first. That's what matters most. 29 is an example. Even when it's not obviously in focus, we can tell this is acanthotic epidermis and it's dark purple. So even on a low quality, not in focus scan, the first thing I think of in that setting is Bowen's disease, squamous cell carcinoma in situ. If something looks kind of like psoriasis, but it's dark blue, dark purple, that's a clue for Bowen's disease. If it looks like a seb, but it's really dark, it could be Bowen's disease. Go closer and look for the atypia. Those are my low power clues to think of Bowen's disease. Here in this case, you can see full thickness epidermal replacement. The whole epidermis is replaced by atypical keratinocytes, big ugly cells, mitotic activity. You'll see usually atypical mitosis if you look around. Sometimes you can get bizarre atypia. Sometimes it's a little not quite as bizarre, like this case is a little bit more monotonous. You will often, in the Bowen's type of squamous situ, you'll often get pagetoid spread. You can get clear cell change, and the clear cell Bowen's can mimic Paget's disease or melanoma in situ. I've got other videos about this, but I will tell you one thing. When you get top to bottom full thickness atypia, I have almost never seen that in melanoma or Paget's disease. I don't think I've ever seen it in Paget's. I've seen focal areas in melanoma, just a small zone where it got full thickness and consumed or replaced the full thickness of the epidermis. But those cases, I think every single one I can remember, were all like big, bad, invasive melanomas with obvious nests, pagetoid spread, confluence, pigment production, all the other stuff that they were 100% melanoma, no stains needed. So I've never seen an in situ only melanoma that had an area of full thickness atypia replacing the epidermis. So that to me is the best clue to help you. Also, that if you find these kinds of Bowen's disease squamous in situ, as they spread out to the side, you will often find that they fill the epidermis and leave the basal layer, giving you an eyeliner sign. You don't always see an eyeliner sign. So if you see it, it's a great clue for Bowen's disease squamous in situ rather than melanoma. But sometimes it's not present in Bowen's, and sometimes melanomas can mimic the eyeliner signs. So, it's not perfect. If in doubt, you can do stains, CK5, 6, or P40 to stain Bowen's, and or you could just do a SOX10 to make sure that it's, or MART1 to make sure that this is not melanoma. Although recognize that in squamous cell carcinoma in situ and other keratinocyte lesions, seborrheic keratoses, basal cell carcinomas too, you can have a colonization by benign dendritic melanocytes, particularly in squamous in situ when there's pigment in it. If you do a melanocyte stain, you will find scattered melanocytes, sometimes even upward scatter of melanocytes that look like pagetoid spread. They'll all be solitary with no nesting. And there won't be any melanoma beyond the edge of the lesion, but that can be scary if you've never seen that before. So do keep that in mind, that scattered solitary melanocytes, even with upward scatter, can be seen in the background of keratinocyte lesions, including squamous cell carcinoma, basal cell carcinoma, seborrheic keratosis. And they're benign melanocytes that are colonizing it. So I've got some images of that. And then look, a bonus finding, a little nevus. So from low power here, you can see some bridging. You could say fibroplasia. You could think of dysplastic nevus at this area, but not over here, because over here we see that even though we've got kind of some dysplastic nevus-like architecture over there, we've got really big atypical cells with abundant pale, dirty dishwater cytoplasm, tons of pagetoid spread. Great example of superficial spreading type of melanoma. No doubt about the diagnosis here. Lots of pagetoid spread, lots of atypia. Very straightforward, kind of puffy, almost ballooned looking melanocytes in this case. And then a bonus finding is we've got this black pigment, and you might say, if you're just starting out in Dermpath, oh, it's melanin. No, melanin is not black, right? Black is always exogenous. The human body does not make black pigment. So I really like to harp on this point. Black can be carbon in the lungs from breathing air in polluted environments that most people have a little bit of. Carbon can be, silver from drinking colloidal silver because you think it'll cure diseases. It does not, by the way. It can be foreign body. It can be, as in this case, tattoo pigment. It can be graphite from getting stabbed with a pencil, but black is not made by the human body. Melanin, no matter how black a melanocytic lesion looks to the naked eye, melanin is always brown. There actually, I think, is also some reddish melanin called eumelanin, but for the purpose of melanocytic lesions, brown is melanin, okay? Your body does not make black. If true black microscopically is exogenous, it's from outside the body, okay? So I think that's useful. And I have encountered sometimes people where they thought about that. I one time heard somebody tell me you shouldn't ink, when you're using surgical marking ink, you shouldn't use black to ink the margins on a melanoma specimen because it would be hard to tell apart from the melanoma. And I was like, oh no, that's not true, because melanin is not black and melanocytes are not black ever. Okay, they are brown when they're making pigment. And a lot of times they don't make any pigment at all, right? So there we go. That's melanoma plus a tattoo. There was one other feature I thought I saw at low power I wanted to point out. Maybe not. All right. I'd call this one superficial spreading type. Some people don't even use those old school classifications or subtypes for melanomas anymore. It's kind of for historical purposes and for pattern recognition for pathologists, but again, clinically doesn't really matter. So this was removed from the foot as a rule out melanoma, or nevus versus melanoma, black spots. And this is a great case because this is a scary thing clinically that is benign and easy to recognize once you find it and know about it. And the key, what is this, Kayla? Talon noir, yeah. The black heel or black claw, right? This is traumatic hemorrhage into the stratum corneum, sometimes from, you stubbed your foot, or I've heard of it happening in people playing basketball and running and sprinting and then stopping and turning back to the side of the court, and that sheer force causing some bleeding. But in any case, it's basically what lay folks would call a blood blister, right? It's blood that is accumulated in the stratum corneum. It's clearly red blood microscopically. I will say sometimes it's degenerated like this. The red cells are broken down and there's serum here. So it's not as easy to see that they're actual red cells, but there is a pocket with serum and stuff in it and a couple maybe inflammatory cells from the circulating blood that got trapped in there. And that clinically, even though it's red to us, it can look very dark and black to the naked eye, but is actually not black microscopically. So always look for that, particularly on acral skin, especially on the foot. When there's a concern for a melanocytic lesion, if you don't see any melanin pigment down here, look in the stratum corneum. And then also, because this happens sometimes, that they're looking for a pigmented lesion and we don't see anything. So I look for talon noir. I look for pigmented fungus up here, like you would see in tinea nigra, which is quite rare in my practice settings, but is a type of black mold that grows in the stratum corneum and can mimic melanoma clinically. And then also we cut deeper levels looking for a melanin or melanocytes here in the dermis. Also, I've rarely seen times where pigmented lesions clinically were actually due to exogenous pigment on the surface. Sometimes it's hard to tell because like here we've got ink, surgical ink that got on the surface, but I've seen times where silver nitrate got onto the surface and had like black particles, and that actually happened clinically and they didn't realize it. I've seen times where people had contact, I think, with walnut trees, the outside of walnut shells, and got black on their hands. So those are all different things that can sometimes cause pigmentation clinically. Anyway, I don't know. There's an expanded differential for you. Acral pigmented lesions can be hard, but I love when we find these because it's benign and easy to diagnose and we're done. One thing I would also point out though is you don't do an iron stain. You're not going to have hemosiderin here because this hemosiderin is due to blood breakdown and processing in the body. And this is now out of the body, right? Past the epidermis, past the basement membrane. So this blood here is just going to sit there. It might break down, but it's not going to turn into hemosiderin. So an iron stain, Gomorrhe's iron, is not going to stain this. And then note also that you can see this same process under the nail. Subungual hemorrhage can mimic melanoma. And so it's like just like talon noir under the nail. So that's another thing to keep in mind when you're looking for a pigmented lesion in the nail. And sometimes it doesn't make a nice pocket. It looks more like this. And you might have a little perikeratosis, like that may have been like there was when the trauma occurred and then it grew and got pushed up, and the patient, by the time they came in for a biopsy, it's been a few weeks and the blood and the perikeratosis have lifted, and now you have new normal keratin underneath because the epidermis has healed and gone back to normal. So even this right here would be good for talon noir. And I usually do add a comment that if there's a persistent pigmented lesion there after the biopsy heals, to go back and biopsy again, because it's possible someone could have bleeding overlying a melanocytic lesion. So, I think that's always good to keep in mind that this should go away after they do the biopsy and it heals. There should be no more pigmented spot there. If there's still pigment, then that means that maybe they could have two things. Go do another biopsy if you're concerned. This is 32. Looks like we're in mucosa because we have epithelium with no granular layer, no stratum corneum, and no adnexal structure. So we're in the mucosa and they wanted a pigmented spot, and look what we found. There's little stippled black pigment here. Some areas it actually starts to look more brown because it's very fine and delicate, but actually in other areas it looks more like black. And here it's actually like embedded, it's laid down on like little wispy fibers of probably elastic fibers are picking up the pigment. Some of it's little specks, some of it maybe is getting ingested in macrophages, histiocytes. So, and this is probably in the oral cavity. So do you know what this is? Something we don't see very often. Yeah, amalgam tattoo, the metal from the amalgam that you got when they were using the drill or whatever, it got flicked and spun away and embedded into the adjacent tissue, or maybe some of it I don't know exactly how it gets in there. I'd always heard that it was from the high speed devices they were using, that some of it got spun down into the tissue, but I'm not a dentist and I don't know if that's accurate. In any case, sometimes you can see little grayish black spots in the gums of people that had like metal amalgam used for fillings or caps or dental work. I know there's been a tendency in recent years, I think, to use less of the metal and more of other types of composite materials. But again, I'm not a dentist. So we rarely, in my practice, rarely encounter this, but these are little metal particles. So another thing that can cause little tiny, very subtle black speckly particles is silver, argyria. Again, we usually see that from people who drink colloidal silver, but silver miners could also get this, but we don't see a lot of silver miners in our geographic area. So other types of metal, gold, which again is rarely seen nowadays, but from gold-containing drugs like that used to be used to treat rheumatoid arthritis and other things. So any sort of metal particle deposition will give little black specks, and sometimes it can be extremely, extremely subtle. This case is abundant here, but like argyria is very, very subtle and hard to diagnose microscopically. 33, this is an immunostain of a lymph node. We can see the germinal centers have nuclei lighting up. So this is a combined stain of Ki67 MART1. So MART1 or Melan-A, whichever name you like, is just two kind of flavors of the same thing, is staining these cells here. And so if you're not familiar with this, you might want to call this, you say, oh, this is a melanoma sentinel node. So they did a MART1 stain and it's staining melanocytes in the lymph node. Well, this must be metastatic melanoma, right? Wrong. This is a lymph node nevus. And so if you're new to Dermpath, you may not be familiar with this. And it's important to know about because these are actually not that rare. I see them relatively often. They're usually very small, very focal things that you might not even pick up on unless you had done a melanocyte marker. So these are out there. It's just we started discovering them as melanoma sentinel nodes were done and immunostains were used to detect small deposits of melanoma in the node. We began to realize, oh, there are little deposits of nevus in the lymph node capsule. That's the best thing, is that these are in the fibrous tissue of the capsule of the node. They usually are thin and kind of linear like this, trickling along in the capsule. Sometimes you can get cells that look like they are right in the subcapsular space. That can be a little bit problematic, especially if you just have one or two cells to tell that apart, because that's where melanoma cells usually deposit. Sometimes they can extend down fibrous septa into the lymph node, which is like stuff like that. There's no nevus here, but these little fibrous bands where that track down into the node where the vessels run, those can be more problematic. So usually these are easy once you know about them. There are sometimes where they can be like more cellular, larger, look like they're floating in the lymph node parenchyma. Those cases can be more challenging. That's beyond the scope of what we're going to talk about today. But this is straightforward. If you see that, that's a lymph node nevus. And note that none of the nuclei are staining with Ki67. So that doesn't totally prove it's benign, but I would say just by the growth pattern and the small size of these cells and the fact they're in the fibrous tissue, which when melanoma goes to the lymph node, it almost always deposits in the subcapsular sinus or makes nodules in the lymph node itself, not in the capsule. With one exception, sometimes in the capsule, you can get metastatic melanoma sitting inside lymphatic spaces, and it can kind of mimic this pattern. So that can be tricky. That's one time where this can be hard. So also nowadays, this is an older specimen. Sometimes also people use HMB45 if they're having a difficult case, because the nodal nevi usually are negative or minimal HMB45, whereas melanomas may have patchy HMB45 staining. I personally feel some people like it. I do think that HMB45 to evaluate nevus versus melanoma is nuanced and a little bit harder than it sounds. So I don't often use it in my practice. And then also nowadays people are using PRAME, which is positive in most melanomas. I think one important thing to know is if you're trying to do that, was the primary melanoma PRAME positive or not? Because if it was PRAME negative, then PRAME's not going to help you here. But if it was PRAME positive, you could try PRAME, and you would expect the melanoma cells to probably be PRAME positive and a nevus to be PRAME negative. So it is more nuanced and complex than that, but basically recognize that these little foci of nevus are present in lymph nodes. They're often very small. They're sometimes multifocal, and they're pretty common. I'd say I see them, and I don't know what the actual statistic is. I'm sure there's a published number somewhere, but I would estimate I see them in 10 or 15% of lymph nodes. And here, see, there's more. There, I feel like when I see it, it's often multiple foci in the capsule. I suspect that these are just from embryonic precursor cells that got stuck in the node capsule as they were migrating out to the skin. I imagine is how this happens, because we see nevi at various levels of the skin, and we see them tracking along lymphatics in the skin. Congenital nevi do that. So why not imagine that you could have it in the capsule of a node? So there you go. And then 34, here's a lymph node. Big nerves over here. Look, it's nerve because once you got a big deep nerve like this, you can see axons right there with the clear space around it is myelin. That's the cross section. And then in longitudinal section, you can see the axon running down the middle, and then these little lines to the side, those are not nodes of Ranvier. I thought that when I first saw this long ago, but someone on Twitter actually educated me. These are something a little more fancy called Lantermann-Schmidt incisures, the vertical incisures of Lantermann-Schmidt, and that's where Schwann cell cytoplasm is coming out after it wraps the axon with myelin. The cytoplasm comes out and joins up with the nucleus of the cell outside the nerve. So try that out on your friends at your next cocktail party and see if they like it, but just a benign and beautiful normal histology there, okay, that we don't see very often in the skin. So here's a lymph node, and this is in parotid. Parotid has acinar cells, little clusters, and they have a purple granular cytoplasm because of enzyme secreting granules in them. And then the ducts are double layer cuboidal or columnar, depending on which ducts you're looking at. And they kind of cystic change like this. These have like some oncocytic kind of change to them. There's ducts right here. And then the tissue looks similar to exocrine pancreas, except that there's a lot of fat mixed in with it. So that's parotid gland, and it's a pure serous gland without any mucinous component, as opposed to the submandibular and sublingual glands, which have submandibular has a mix of serous purple cells and mucin cells, and sublingual has pure mucin cells. So as do minor salivary glands. So there you go. There's some histology for us. Here's a lymph node, and so this was removed as a sentinel node. For head and neck melanomas, often when they do the radioactive tracer, the draining is often to a parotid node, if it's like from the, say the melanomas from the temple or the ear. So I often see nodes in the parotid taken out, and then they take the parotid, partial parotidectomy with it a lot of times. Sometimes the node can be in the parotid, and one weird thing that I wanted to make sure you knew about, if you're watching this and you're new, is that in the parotid tissue can be present inside the lymph node. Normally, epithelial cells, we do not want to see inside lymph nodes, right? That worries us for metastatic carcinoma. But in intraparotid lymph nodes, this one is right next to the parotid, but when they're down in the parotid, it's normal to see parotid glands and ducts scattered in the lymph node. And guess what? Parotid, some of the cells of the parotid glands are SOX10 positive, and some parotid salivary gland tumors are SOX10 positive, and that's true also of eccrine coils in the skin. SOX10 positivity is normally present in those cells, and some sweat gland tumors like cylindromas and spironomas are SOX10 positive. So SOX10 is a great sensitive marker for melanocytes, but it's not specific. It stains neural crest, things like nerve sheath tumors, and it also stains a subset of salivary and sweat gland tumors and other stuff. So just know that. All right, so in this lymph node here, the point of this specimen actually was to see that this is metastatic melanoma. So this is why we do stains. At low power, it can be a little hard to pick up on this, especially when it's small and focal, because melanocytes often have kind of some similarity to histiocytes, I think. They can look a lot like histiocytes, they're kind of the same color and similar shaped nuclei sometimes. So these here, these spindled cells here, I think, and these little nests are the melanoma cells. You can see in this case pigment production, but you don't always have that. So if you did a stain, you would see that these are melanoma cells, and they're in the subcapsular sinus underneath the capsule of the node, that space between the node parenchyma and the capsule, which is where usually metastatic deposits of melanoma go first. This is a case though which is tricky compared to what I just showed, and I just said, oh, nevus runs as a little linear thing in the capsule, and melanoma doesn't usually do that. But yes, sometimes it does. And here's one of those times. Now, thankfully, I think these cells are more hyperchromatic, atypical looking. But it's easy to say that because we got obvious melanoma down here. So, and also it's a study set and it's labeled, so we know the history. But here, I think what's happening is this is a lymphatic space right here. And so sometimes the nevus cells can fill up, the metastatic melanoma can fill a lymphatic, an efferent lymphatic, as it comes into the lymph node capsule, and that can kind of mimic metastatic melanoma. So in those kind of cases, you might need stains, especially if that's the only thing you've got. I feel like when I've seen that, oftentimes there have been other foci inside the node, but not always. So in any case, it can be challenging in some cases. These lymph nodes are not my favorite kind of specimen to deal with because they take a long time and they can be difficult and frustrating. So that's melanoma here. Remember that you don't always see pigment. I would also point out while we're here, just if you've not looked at a lot of lymph nodes before, for anyone watching this, this is not melanoma. This is sinus histiocytosis. You get pockets and clusters of histiocytes that fill up the subcapsular sinus and the sinusoids going down into the lymph node in reactive lymph nodes is a common benign finding. I remember as a first-year pathology resident, I would constantly these would catch my eye and I would go look and study it because I was worried it was metastatic tumor. With practice, your eye will get used to this. And I still, though, from time to time, will see one and I'll just go down at a higher power and double check that they look like histiocytes. With immunostains, you can tell it apart, but you don't always need that. With practice, you can learn to recognize these. They have bland nuclei that are kind of oval or almost bean-shaped, very fine, delicate chromatin, abundant, fluffy, loose cytoplasm that kind of blends in with its neighbors. So it doesn't have well-defined cell borders, kind of loose aggregates. So that's sinus histiocytosis, and it can kind of mimic, particularly when you're looking for melanoma. Melanoma cells can have overlap with histiocytes, like I said, so it can be a little challenging without practice and even with practice. The other thing is, I think I found some in here, is that pigment in a lymph node is not always bad, okay? And especially if a person had a melanoma, they may have had pigment production by the melanoma, some of which leaked out into the dermis from pigment incontinence, got picked up by histiocytes and drained to lymph nodes. So we see melanin pigment in lymph nodes sometimes. I mean, pretty often actually in histiocytes. You could do a stain and this would be negative for SOX10 and usually negative for MART, although sometimes you can get some cross-reactive staining with MART you got to be careful with. So that's important to know that you can have that. Also, patients that have significant inflammation in their skin, or if they have eczema or other inflammatory process, the pigment of their epidermis falls out, can go to lymph nodes, and you can also get reactive lymph nodes in the setting of eczematous dermatitis called dermatopathic lymphadenopathy, which is a reactive lymph nodes with melanin pigment drained to them in the histiocytes that is in patients with bad eczematous dermatitis. So important to know that pigment does not prove melanoma. I see this all the time in benign lymph nodes with no melanoma. So if you're not familiar with that now, you are. Oh wait, let's go to the other section here. So shave biopsy of a very darkly pigmented lesion, but a very discrete lesion. From low power, you can see it starts right here, nothing beyond, and it stops right here. It's like a very discrete, and clinically this would have been a dark, like black spot that was sharply circumscribed and not very large, probably on the extremity of a young adult woman. That would be like the classic clinical STEM in a test question if I were making one, but you know, they can sometimes be other spots. And darkly pigmented melanocytes. The melanocytes are plump spindle cells in kind of large nests that are kind of hanging down or raining down from the epidermis with elongated kind of reedy in between them. And we can't, unfortunately, the scan's a little out of focus. We can't really see the cytology. They're plump, kind of larger, but relatively uniform. They all look the same. They have grayish cytoplasm with fine pigment, and then a band of densely pigmented melanophages, histiocytes with melanin, not melanocytes underneath them, which is classic. And the pigment may also be prominent in the epidermis. So this is great for a pigmented spindle cell nevus, also known as Reed's nevus after Dr. Richard Reed, who described it. And sometimes these have vertical orientation of the nests, in which case they can be described as kind of bunches of bananas. And that same terminology has been used for Spitz nevus, because sometimes pigmented junctional Spitz nevus can have a lot of overlap with pigmented spindle cell nevus of Reed, and some people have proposed that they are the same thing or two flavors of the same thing. I certainly think there's a lot of overlap between a junctional Spitz nevus and a pigmented spindle cell nevus, okay? The other thing though is that sometimes the melanocyte nests can be horizontally oriented and go reedy to reedy, in which case they can really look similar to dysplastic nevus. And then the cells are kind of plump and big, so you might be tempted to say, oh, moderate or even severe dysplastic nevus because they're kind of larger, plump cells. So I feel like recognizing the very sharp circumscription, the band of pigment underneath, the kind of uniform cytology is good for pigmented spindle cell nevus of reed. And these are benign, but sometimes if they're transected, people will biopsy them. I feel like most of the time on a shave, you can see both sides because they're small and they're easy to shave underneath. If it's a big lesion, then you got to be really careful, okay, about that. And I am not, I feel like occasional pagetoid scatter in the middle of these is really common, just like over top of Spitz nevi. I feel like it's pretty common to see some pagetoid scatter. And if the lesion otherwise fits nicely for a pigmented spindle cell nevus, I have no problem with that. I feel like I'd see that in, I mean, majority of these, honestly, to see occasional pagetoid scatter. So that does not bother me. I do not want to see single cells trickling out at the edge. That would make me nervous. So pigmented spindle cell nevus. This case is 37. And this one at low power looks like a dysplastic nevus. Bridging nests. It's got nice bridging. It's got nests. And you could say, oh, it's good nesting, so not much pagetoid spread or single cells. But this is an older patient. They've got some solar damage, I think, elsewhere in the slide. It's not really easy to see here. And even though it looks nested, the cells are pretty atypical. Big nucleoli, large atypical nuclei. I also don't love to see like large junctional nests, especially in older sun damaged patients. In younger people in their nevi, it's not uncommon to have large nests. But the other thing here is that while we're busy focusing on the nests, it's easy to miss the fact that there's a ton of pagetoid spread and confluent single cell growth all throughout the background. This one's pretty obvious, I think, if you just look even for a minute. But I've seen cases where these so-called, I think this fits nicely with the so-called nested melanoma of the elderly, which is usually in older patients, often on sun damaged skin, where you get real big prominent nests of atypical melanocytes, and that nested appearance can kind of falsely reassure you. And there can be, usually though, I think when you go closer, you'll see atypia. And also if you look, or if you use stains, oftentimes just looking carefully, you can see it. You will find there are actually a lot of single cells with interreedy growth and near areas of confluence and pagetoid spread in the background. It's just distracting to see the big nests. Here, there's a lot of cytoplasm in those background melanocytes, so there's actually no doubt. It's very straightforward melanoma at closer examination. Look at all those cells, pagetoid everywhere, right? But sometimes I think that's a trick to be aware of, that big nests in older patients in sun damaged skin especially, be very wary about if you have large nests with atypia, or if you think it looks like a dysplastic nevus and they're very sun damaged and it's got moderate or severe atypia. Be careful, look for pagetoid spread, look around carefully, look at the periphery of the lesion. Don't just stop and say, oh, it's nested, it's fine. And then the other thing I think that we could point out here is that sometimes, even though melanomas we teach don't have an eyeliner sign, they replace the basal layer, sometimes they don't. And one of the times that you can see this exception, I think, is in these kind of nested melanoma in older sun damaged skin. The nests kind of float up and leave the basal layer of darkly pigmented. In this case, the darkly pigmented cells here are actually, most of those are keratinocytes. So they leave like a little bit of a rim of keratinocytes underneath them. So sometimes I've seen benign nevi with large nests that float too, but I'm really wary, especially in older sun damaged patients, that pattern. I've seen that multiple times in nested melanomas like this. So I don't know how specific that is, but one of my partner, Sarah Shalin, had pointed that out to me years ago. And I've been keeping an eye on it, and I feel like that was a really astute pickup that she had. And I've definitely seen multiple times where that was a great clue to help me recognize a nested looking melanoma that also had pagetoid and stuff in the background. So I have seen nevi with this kind of eyeliner rim underneath them, but also you can see it in melanoma. So again, we say the eyeliner sign is good for squamous in situ or for Paget's disease, but melanoma, no rule's perfect, right? Melanomas can sometimes do it, but also here, we've got obvious nests, obvious pigment. I mean, this is clearly melanoma, not squamous in situ, not Paget's disease, right? So again, don't fixate too much on the little clues, guys. All right, that's a good example. So this is a kind of scary looking case because it's got the kind of architecture of a intradermal nevus. There's actually some junctional component over top, but most of the cells are intradermal. And they're kind of like trickling between collagen in a very benign pattern, but they've got large, hyperchromatic, really dark nuclei, but other areas that look like a regular nevus. So when we see this, usually we see these as just scattered occasional random atypia in an otherwise normal nevus, but sometimes it can be more pronounced like here, which can be kind of scary. So this has been called ancient change in a nevus. The idea being that this is nevus has been around so long that the cells have gotten old and kind of gotten degenerative nuclear atypia. I honestly have no idea if time that a lesion has existed really causes this change, but it's been used elsewhere in pathology, like for schwannomas that get this similar kind of hyperchromatic pleomorphic cells, but no mitoses or other atypical features. So if you stained this, it would have very low Ki67. It would be probably negative on PRAME, etc. I do feel like it could be more concerning in a lesion like this, where so many of the cells have that, but we see these kind of random, really dark, hyperchromatic, smudgy nuclear chromatin atypia in normal nevi all the time and just disregard it. So it can be more pronounced, but this is called ancient change. And this kind of idea of degenerative nuclear atypia, sometimes in certain settings in pathology, is also called symplastic change. Symplastic, S-Y-M, plastic, is the same kind of idea as atypia, but in a benign lesion, like a benign type of nuclear atypia. So you can do some more reading about ancient nevus if you want, but nevus with ancient change is a benign but kind of scary looking. The one thing that does help me here is we don't have any melanoma in situ over it, and it is extremely rare, vanishingly rare to have melanoma arise as a dermal only thing. Metastatic melanoma does that. Melanoma where the in situ has ulcerated or regressed can have only stuff in the dermis, but a melanoma arising de novo in the dermis is exceptionally rare. And some people argue it doesn't exist, but that's outside the scope of this lecture. And finally, here we have probably a partial amputation of a digit. You can see the acral skin up here surrounding the whole thing. And then this is nail plate, this pink line here. Orientation's a little hard to tell. Is this matrix? I think probably this is actually the lateral edge of the nail where it goes down under the lateral nail fold. And then maybe this is some of the matrix in here. I think we're kind of oriented tangentially, but it's kind of hard to tell because we can't see any bone in here. So it's not like a perfect cross section of a distal finger. So I don't know, but in any case, we know we have nail and matrix / nail bed epithelium underneath it. And it's subtle, but in that we can see the reason that they amputated or excised this finger is that there are too many nuclei along the basal layer, and we don't have the corresponding stain, unfortunately, but many of these nuclei belong to atypical melanocytes that are confluently replacing the basal layer underneath here. And so this is a sneaky example of a subungual melanoma in situ. There is some pigment in here, so pigment production probably, and then they probably by these melanoma cells underneath, but they're really hard to tell. I think I would definitely want to see an immunostain here. Very suspicious because of the increased cellularity. Like there's too many nuclei, it's too jumbled. To me, that's one clue that I go think, is there going to be melanoma in situ hiding in there? If I see busy, like compare it over here. This is normal, a nice even basal layer. This is not normal. There's too many nuclei. What are those extra nuclei? In this case, they're melanoma in situ cells. So that is a sneaky example. I find biopsies for pigmented lesions under the nail to be really challenging. They're often very subtle. We often have to do stains and deeper levels. I find them very, very difficult to interpret. So if you struggle with those, you're not alone. I do too. And as a nice little bonus before we end, a canal of Suke Hoyer. Sorry to my people out there speaking French that know the proper way to pronounce that, but also known as a normal glomus body or glomus apparatus, a little arteriovenous channel lined by modified pericytes, aka glomus cells. And here's another one, and you see those most commonly in the distal extremities near the nail bed. You can also sometimes see them elsewhere in the body. That's what glomus tumors are, either arising from or recapitulating. All right, if you've stayed here to the bitter end, you get a bonus point from me. Thanks for watching and have a great weekend.